The next speaker is James Goldberg, who is going to speak on expanded carrier screening, optimizing panel design. Jim?
So Jim is Chief Medical Officer at Council. He is board certified in obstetrics and gynecology, maternal fetal medicine, and medical genetics, and he is a founding fellow of the American College of Medical Genetics. He has previously been the director of the reproductive genetics unit at the University of California, San Francisco, and subsequently co-director of the Prenatal Diagnosis Center at California Pacific Medical Center and partner at San Francisco Prenatal Associated.
Thank you, Tony and Jean, and thanks to the organizers for inviting me back to speak to this group. What I'd like to talk to you today about is what's happening in expanded carrier screening. And there are a lot of changes both in guidelines for expanded carrier screening and actually how the test is being performed. And hopefully I'll be able to bring those together in this talk and give you a sense of which way expanded carrier screening is moving. My disclosure slide is 3 years ago I joined Council. Before that I was in clinical practice doing reproductive genetics and counseling people about these tests, so I have lots of experience with that, but in the past 3 years I've been working full-time as the Chief Medical Officer at Council, which is a screening company. So here's what I'd like to cover today, and I've broken the talk into really 4 different areas. We'll talk a little bit about guidelines and how those are changing. Then we'll talk about some of the data, and that's data that has brought about some of the changes in guidelines, but is also data supporting the move towards expanded carrier screening versus targeted ethnic-based screening. Then we'll talk about the design, which was the title of my talk, so we definitely will spend some time talking about panel design and what disorders make sense to put on a screening panel and is more better. We'll talk a little bit about that. And then if we have time, Tony gives me the warning sign, we'll see, but if we have time at the end, we'll talk a little bit about practical implementation, screening into clinical practice. So first of all, I'd like to spend a couple of minutes talking about what's changed. And just before I get into that, I just want to point out, many of you already know this, but 80% of children born with a genetic disease have no family history. I remember when I was in practice and would start to talk about screening with patients, they would say, "Oh no, I don't need that. I don't have anything in my family." And I'm sure you have all heard that. And for me, the fact that they say that means that they're candidates for expanded carrier screening. That's just the group that should be screened because they don't have any history of screening. And the impact of screening, at least in the United States, up to 18% of infant hospitalizations are due to genetic diseases. So this is a common problem. And I'll give you some numbers in a little bit about what we can detect with expanded carrier screening. So some of the changes that happened in the past year, some of the major ones were changes in guidelines by ACOG. And I realize that most of you are not from the United States and don't follow strictly ACOG guidelines, but I would argue that they have impact in other groups and in other areas. So I want to spend a couple of minutes talking about that. And ACOG issued 2 new guidelines in the past year. Number 690, which is carrier screening in the age of genomic medicine, and 691, which is carrier screening for genetic conditions. And I'll talk a little bit about both of those. The second one, 691, is really a consolidation of all the individual ACOG guidelines for carrier screening into one document, plus expanding it a little bit, which we'll talk about. So this is from 690, the first bulletin, and this was a big change for them because previously ACOG had only supported ethnic-specific or limited ethnic screening for certain conditions and a couple of disorders for general pan-ethnic screening. But what they're saying now in this practice bulletin is that ethnic-specific, pan-ethnic, and expanded carrier screening are acceptable strategies, screening strategies, with counseling, education, guidance, and appropriate disease panel selection. And so this was an acceptance by ACOG. It wasn't saying that everyone needs to be offered all of these, but that these are acceptable approaches to screening now. So this is a big change and comes a long way in terms of ACOG, at least, philosophy towards expanded carrier screening. The other one is 691, the one I talked about consolidating the recommendations for general screening. And really the only changes with this updated bulletin, the main one is the addition of spinal muscular atrophy. And on the slide you can see little dots for the American College of Medical Genetics recommended disorders, the green ones, and the ACOG recommended disorders, which are the red ones. And before this new bulletin, ACMG recommended screening for cystic fibrosis and spinal muscular atrophy in the general population, where ACOG only recently included spinal muscular atrophy. Also, if you look at the Ashkenazi Jewish conditions, you can see that this is one of the ethnic-specific groups where screening is recommended, but there is no consensus between the American College of Medical Genetics and ACOG, with ACMG recommending a much larger panel. So still, it's fairly limited in terms of the recommendations by ACOG for screening in the population. And we'll talk about some of the issues with this. And some of the data I'm going to present in a few minutes refer back to the screening guidelines. So that's why I wanted to spend a few minutes just updating those and summarizing those. I love this quote, and I try to throw it in usually somewhere in my talk, but it's by Francis Collins, who's the director of our NIH in Washington, and this was in his 2010 book. And what he said at that point, and this is really before the era of expanded carrier screening, is that it is likely that within a few decades, people will look back on our current circumstances with a sense of disbelief that we screened for so few conditions. So looking ahead, he foresaw what is currently happening. Okay, let's look at some of the data supporting expanded carrier screening versus the more limited guidelines, at least in the United States, that currently exist. And some of this data I presented last year, but we've done a few additional refinements of it, so I will bring you up to date, and many of you may not have heard it in other venues, so I'll spend a few minutes talking about it. And this data is primarily from a JAMA publication from August of 2016, looking at the largest series of patients who underwent expanded carrier screening, almost 350,000 patients. And what we looked at in this study, we looked at actual screening results broken down by ethnicity. And what we looked at in terms of reporting results is the odds of having an affected child. And the reason that we picked that metric is if you look at just carrier frequency, the chance of having an affected child may not strictly relate to carrier frequency. While most of these disorders are autosomal recessive, some are autosomal dominant, and Fragile X is a significant disorder. So as you all know, the chance of having an offspring with Fragile X depends on repeat size. So we figured the best way to level the playing field among all the disorders was to report the chance of having an affected child. And we took into account, for example, the size of the repeat when calculating that. And a couple of key questions that we tried to answer with this study is, how does expanded carrier screening compare with current guidelines? And by current guidelines, I mean the ACOG and ACMG guidelines, which I showed you earlier. How does that relate to screening in a diverse population? And what are the relevant metrics in evaluating carrier screen efficacy? And we talked a little bit about that just now. So 346,000 patients were screened, and the panel that was used for these screening results were about 100 conditions, actually about 94 conditions, all serious conditions. The other mild conditions that were included in some of the screening panels earlier were removed from analysis. And the important thing is that we looked at results across a variety of ethnicities. You can see that the mixed or other Caucasian and the Northern European are the largest ones, but you can see that there are significant other groups, and there are at least 5,000 individuals in each of the various ethnic groups, and much larger than any previously reported carrier screening statistics in these populations. What we showed was that ethnicity-based carrier screenings, and that's carrier screenings based on ACOG or ACMG guidelines, miss a significant percentage of pregnancies in general, but in specific in certain ethnic groups. For example, if you look at East Asians, 94% of serious disorders were missed by if you use just the ACOG or ACMG guidelines. In the Hispanic population, about 79% of serious disorders were missed. Northern European, 65%, and even in the Ashkenazi Jewish population, which has its own screening panel, using just the guidelines, 55% of serious conditions were missed. And a number that wasn't in the paper, but that we calculated subsequently, that 1 in 550 pregnancies based on calculated ethnicity data in the United States were predicted to be affected with one of these serious disorders. And you can see on the right the breakdown by ethnic groups. It changes depending on the specific ethnic groups, but overall, at least using the ethnic mix in the United States, the incidence is 1 in 550. And if you compare that to other things that we commonly screen for example, Down syndrome in the general risk population is about 1 in 800, neural tube defects about 1 in 1,000, cystic fibrosis 1 in 3,400 in Northern Europeans. This is more common than these disorders. So while each of the individual disorders, or many of the individual disorders, may be rare, in aggregate, it comes to a risk of about 1 in 550. So it's really pretty common in aggregate. So some of the things that this study supported was that ethnicity and family history should not be used to limit carrier screening. The risk of significant number of severe and profound conditions is present across the population, not just in certain ethnic groups. And standard risk assessment of serious actionable disorders is really preferable to screening for limited guideline-based screening. Okay, let's talk about panel design, which I said we would. Much of this data comes from a recent publication in Genetics and Medicine this year. And what we looked at is how we try and design an optimal screening panel and some of the reasoning that goes into why we made certain design decisions in terms of picking disorders for the panel. Initially starting out, we reviewed over about 650 disorders. And we narrowed that down to about 175 disorders. And some of the issues we looked at, which I'll speak to in a little bit more detail, are first of all the severity of the conditions. We wanted to make sure that all the conditions that we had on the panel were severe or profound and not mild and moderate. And that's not such an easy distinction to make. Many of you are aware in March of 2015 there was a document put out by 5 different groups in the United States, ACOG, ACMG, Society of Maternal Fetal Medicine. It was a points to consider for expanded carrier screening. And when we first got together to meet for thinking about how we were going to write that panel, the first thing we did was, let's just see if everyone thinks the same about the severity of different disorders. So we put together a panel of about 20 disorders, passed it around the room, and had everyone rank them, figuring that it would be pretty consistent. No way. So it's not so easy to rank the severity of conditions. And what we tried to do was look at different characteristics of severity, early death, other things like that, and then compare those back to a panel of disorders in terms of deciding whether they should be included or not. But it's not straightforward, and many of you know of the incredible amount of time that went into putting disorders, at least in the United States, picking disorders for newborn screening. So it's related to that, so it's not an easy task. Then we looked at actionability based on provider and patient discretion, whether they would do something with the results. We did look at prevalence, and the super rare disorders we did not include. And then we looked at sensitivity, and we'll spend a little bit of time talking about that. What is the detection rate that we would predict for a certain disorder, and how that impacts overall testing? So, several things which have had an impact on the sensitivity, we'll start there, are first of all full exon sequencing. And that provides a significant detection rate as compared to using just targeted mutations. Then we'll talk a little bit about custom assays. Some of the genes are quite complex in terms of making calls on whether a patient is a carrier or not. And we'll talk about how that impacts the overall panel. Another thing which impacts detection rate is the ability to detect deletions and duplications. So we'll talk about what that adds to detection rates when designing a panel. And then we'll spend a few minutes talking about the importance of real-time curation when you're doing full exome sequencing. So this is what the distribution of disorders from our JAMA paper looks like. And these are the types of disorders, and the numbers are the detection rates, or the predicted detection rates of affected individuals per 100,000. And we broke it down this way to kind of give you, in this tree map, to kind of give you a visual representation of what the screening looks like. On the right-hand side are the special cases. And what I mean by the special cases are that they're either done by a non-next generation sequencing methodology, or that the calling of disorders are quite complex because of the genes. And I'll give you an example of that. But some disorders have many pseudogenes and are very difficult in terms of making the call of whether they're carriers or not. So included in that are Fragile X, and SMA, and congenital adrenal hyperplasia, and one of the hemoglobinopathies, hemoglobinopathy A alpha. And you can see the other breakdown, at least in the general population. CFTR, cystic fibrosis, is a common one, but I will also show you in another slide that changes by ethnicity. So how do we maximize the detection rate? And then after that, a little bit, why is it important to maximize the detection rate? And first of all, this is one of the complicated genes. Most of you are well aware of this for alpha thalassemia, that there's 2 genes, hemoglobin A1 and A2, on each chromosome, so 4 genes total. But they have identical coding sequences, and there are frequent deletions. That's a problem for next generation sequencing that just looks at the coding sequence. And you can see that if you have 3 copies, you're a silent carrier for alpha thalassemia, but that can arise in 2 different configurations. If you have 2 copies, depending if it's in cis or trans, either being on the same chromosome or different chromosomes, depends on what the inheritance risk is, even though all of these are carriers. So it gets to be a very complicated gene in terms of making sure that you provide the right diagnosis. And one copy you have hemoglobin H, and then if you have 0 copies, of course, you have hemoglobin Bart's and you're affected. So starting out from just CFTR, which much of the early screening, and at least in the United States, and I think around the world, CFTR isn't necessarily universal in all places, but where screening is performed, it's the most commonly done one. You can see what a small part of the total possible detection rate with the larger panels that the CFTR turns out to be. Here is, again, looking at that same tree map you saw earlier, but you can see in the red is even if you're doing full multi-gene, full sequencing, you still have these red areas which you don't detect. And how do we increase the detection rate? We do that by doing panel-wide deletion and duplication calling. So what that does is add that small amount that you saw in terms of increasing the detection rate. And you can see with that, the red area is gone, and essentially you're picking up greater than 99% or close to 100% of all mutations in these genes. This is, it's a little small, but I think the thing to look at is the breakdown of the differences, and the reason I put it in was just to show you that among different ethnic groups, the breakdown of different disorders is different. So it's not just that detection rates are different, but it's actually different disorders that are more prevalent in one ethnic group versus another. That's why trying to design ethnic-derived screening is so difficult, and pan-ethnic screening is much better as covering in a universal way this type of screening. Just to give you a sense of all of these extra steps in terms of the laboratory methodology, what you're adding, if you look at a typical targeted genotyping panel, you would pick up roughly about 50-55% of disorders, with full exon sequencing about 68%. Adding in those technically challenging disorders, the one in the green on the right-hand side of the other tree maps that you saw, adds in another 30%. And then adding in deletion and duplications, while percentage-wise it's not that great, it is about another 2%, and you'll see clinically why that's important in just a minute. So with panel testing, like this, using deletion, duplications, and full sequencing, as many companies are offering now, you can detect over 99%, and it identifies 1 in 42 couples, and that's another important statistic, what the at-risk couple rate that a carrier screen provides. 1 in 42 couples using this approach would be identified as at risk for one of these serious or actionable disorders. This is an example that I like to show because it really brings home what the benefit is of having higher sensitivity or higher detection rates. And let's look at the example on the left of a mixed ethnicity couple. The woman is detected as a CF carrier. Her partner is of Hispanic origin, carrier status unknown. So if you look at targeted genotyping, let's say with a 97 mutation panel, which is typically offered, at least in the United States, the detection rate for that is reported at 78%. So the carrier couples missed would be 1 in 5. So what we call that is the residual risk. So even after testing both of them, you have a residual risk. With doing full sequencing plus deletion and duplication, you have a detection rate of over 99%. So the residual risk is much lower. It's 1 in several thousand, and if you do a Bayesian calculation and back calculate the number. So it decreases the residual carrier rate when you're talking to a couple in terms of their risk of having a child. It never drops to completely zero unless you could pick up all mutations, but it drops very significantly with the increased sensitivity of the disorder. So important things to look at, as I mentioned, were the at-risk carrier couple rate and the predicted affected pregnancy rate. And we talked about those and how those help describe the characteristics of the test that I think are useful clinically. The other thing I wanted to talk just for a minute about is real-time curation. As we do full exon sequencing, as you know, what we find are a number of VUSs. And that's always a concern in terms of whether those are disease-causing or not, and what do you do with those? And some labs have a list of ones that they look at and whether they pass it or not. Another approach is to do real-time curation, and I don't expect any of you to read this, but I wanted to give you an example of the complexity of the curation process, and these are the ACMG guidelines for curation. And what we do in our testing is do curation in real time. So as a variant arises, it is looked at and analyzed by our curation time in real time. And so while the rest of the test is being completed, decision is being made. And we don't report out, and since this is a screening test, any variants, but each new one that we see is curated in real time. So let me just spend the last couple of minutes talking about how this should be, or how I think this should be incorporated in clinical practice, and the approach that I used when I was seeing patients. The traditional approach, or I would call it the old approach, would be to do sequential screening using targeted mutations. And the first thing is you screen your woman, the patient who you see in clinic. If it's negative, then you're finished. If the partner is positive, then you need to counsel them and determine what the residual risk is for having a disorder. Also, if they've only had targeted mutation screening, you need to counsel them about the improved detection rate if you go on to do full sequencing and deletion duplication testing. If that is negative, you're fine. If it's positive, then obviously you discuss the various reproductive options which are available to the couple. What I think is better approach, but gets a little more complicated, is to do tandem screening. What I mean by tandem screening is to screen both the couple and her partner at the same time. And this is what many people have moved to, is tandem screening of targeted mutations. So you screen the woman and her partner. If both are negative, you're finished. If one is positive, then again, you have the same issue of calculating residual risk, offering full sequencing or deletion duplication. And the disadvantage of that, as you might imagine, is that it adds extra time in terms of the additional testing. If you're doing this preconception, it's not as big of an issue. So obviously, I think preconception is the best time to do this. But if you're doing this at mid-gestation and you're already at 15 to 18 weeks, it's a significant problem to add another 2 to 3 weeks onto the analysis process. And obviously, if both are positive, again, you discuss reproductive options. What I think is the best approach is tandem screening using sequencing. You screen the woman and her partner. If both are negative, you're finished. If one is positive, you're also finished because there's no additional testing that needs to be done on the other partner. You've already done sequencing and deletion duplication testing. And the same thing if they're both positive, then reproductive options.
Jim, do you have 1 minute? Oh,
okay.
Fantastic.
How about that? Tony and I rehearsed that. So
Fantastic.
thank you. I hope that I've given you an overview of what's happening with expanded carrier screening, and it's rapidly evolving, and what we're seeing around the world is much more interest in expanded carrier screening. So I'm hoping some of the data that we've generated in the United States will be applied and used as we see more expanded carrier screening being done. Thank you.